Today we're going to talk about atrial arrhythmias and treating them in actual modern practice. So we have a few objectives. The first is to identify and classify the principal types of cardiac arrhythmias that originate in the atria, the upper chambers of the heart, the supraventricular arrhythmias, to recognize arrhythmia substrates and the role of ablation therapy in modifying them, which means that we have to remember that the heart is a muscle, so what goes on in the muscle is occurring literally in the muscle, and therefore its treatment involves the muscle of the heart itself, which is an electrical organ as well as a mechanical pump. To appreciate the role of intracardiac electrograms in diagnosing and treating arrhythmia. Some of you know what this means, others will learn it in the course of the talk, but we'll specifically refer to intracardiac electrograms, which are the electrical activity measurements taken from within the heart rather than outside the heart. You'll see what I mean in just a second. And finally, to understand the effectiveness and limitations of anti-arrhythmic medication. So a few objectives, and I hope that this will be of value to you, because no matter what we do in our careers, we're all at our heart's internal medicine physicians first. We have to understand basic human anatomy and physiology first, no matter what our specialties will be thereafter. So just a quick review of normal heart rhythm. This is a view of the heart. Everyone knows what it looks like. Beautiful organ, 2 atria, 2 ventricles. The cardiac rhythm initiates in the sinus node with a regular, rhythmic, physiologic expansion of coverage of heart muscle by a wave of electricity that arises from those cells of the sinus node. That depolarization wave will stimulate the muscle through which it traverses to contract. So you get atrial contraction when the impulses travel through the atria. When the impulse hits the AV node and gets delayed a little bit, that gives time for the ventricles to expand, fill with blood, and then the impulse travels through the ventricles and leads to their contraction subsequently. So very nicely organized. This is a schematic of what that wave front looks like traveling through the atria and the ventricles to give you normal rhythm. Now let's just quickly review at our typical approach for measuring electrical activity in the heart. As you all know, it's the electrocardiogram. You've been doing this since medical school or even beforehand. And the electrocardiogram is simply a way to measure electrical activity of the heart from the outside of the heart, from literally far outside the heart, which is the body surface. By putting patches on the skin at various parts of the body, we can use those patches or detectors to see and measure electrical activity that gets projected from within the heart muscle to the outside. So electrical activity is going on in the heart, just through that, like that cartoon schematic a second ago, and we can get snippets of measurements of it from the external surface of the body via these patches that constitute the 12-lead ECG. And the different views of that electrical activity are represented on the ECG in different leads. So AVL would be a look at electrical activity of the heart from the left shoulder, that perspective. What's going on from that perspective? AVR from the right upper shoulder. Lead 1 directly on the left side. Leads 2, 3, and AVF down at the bottom of the body, looking up at the heart and seeing what's happening if you're looking up at the heart. And when you put all this stuff together, you get the complexes that we see here in a typical normal healthy heartbeat. And a commonly representative view would be something from lead 2, for instance, in which the P wave represents atrial electrical activity globally projected downward toward the inferior leads. And because the activity is coming from the sinus node way up in the top of the heart and projected downward toward the bottom of the heart, the inferior leads 2, 3, and AVF, would see an upright deflection of activity, and that's the P wave. And it's relatively broad-based because it takes time for that activity to travel through the atria, and it's relatively low amplitude because the atrial tissue is kind of thin. It's like beef carpaccio, a very thin muscle, so it doesn't generate a lot of amplitude. Then there's a little bit of a delay as that impulse gets delayed and processed in the AV node, so nothing's happening, no electrical movement anywhere, isoelectric line, and then there's the rapid deflection of the ventricles. So ventricular activity, again, depolarized from an AV node, which is up top, downward toward the ventricles. So you see a sharp spike upward and then downward as it recovers, and then the repolarization wave of the ventricles happens thereafter. And that's the full measurement of electricity from far away, from an inferior lead in the feet, for instance, looking up at the heart. And again, that's kind of like a Google Earth 5,000 foot up view of what's going on in your neighborhood. those few inches or feet away from the heart are actually long distances from where the electrical activity actually arises from within the heart itself. I know that's a lot of review, but I just wanted to get us all on the same page so we understand what the ECG is, what it does, and what it doesn't do. And it's very powerful, but it's not all powerful. This is what a 12-lead ECG of somebody with normal rhythm looks like. Upright P waves seen in the inferior leads. That's a nice representation of sinus rhythm. I still read ECGs the way I did in medical school. Rate, rhythm, axis, intervals, waveform. And you know this. The rate normal rhythm at rest should be between 60 and 99. Upright P waves in lead 2 represent sinus rhythm typically. The PR interval less than 200 and the QRS of less than 120. So let's talk about when that normal ECG is deviated and becomes abnormal or non-physiologic. And this would be the narrow complex tachycardia situation. So what are the narrow complex tachycardias? They're simply heart rates that are greater than 100 beats per minute and a QRS duration that's less than 120 milliseconds. So a narrow complex rapid ventricular rate. This is a typical narrow complex tachycardia, rates greater than 100. And what does that mean when they're narrow complex? Well, it means that the rhythm originates either in the atria, the upper chambers of the heart, or in some fashion depends on the AV node and travels through the AV node, because anything that hits the AV node, if the AV node is normal and the subsequent downstream conduction system is normal, will result in a rapid progression of electricity through the ventricles and therefore a narrow complex of the rhythm. So how do we understand these? Well, I still read, again, ECGs the way I did when I learned in medical school, which is earlier than what the stage of training you're in right now, but I would just encourage a system that you keep sticking to. That way you don't miss things. So what I always like to do is remember that we first have to review the clinical data, because remember that these ECGs don't exist in a vacuum. They're attached to a living, breathing human being. Understand the clinical data. What are the pearls? What's the context? Every individual has his or her own clinical context. Understand that first while you're trying to interpret the data. There are some ECG patterns that can be recognized at first glance. When they can't be immediately understood or recognized, the next thing that I always search for is the P wave. We joke that even an orthopedic surgeon can find the QRS, but a P wave takes a little bit more looking, and sometimes it's very hard to find a P wave. Sometimes there isn't a P wave, and that's very helpful information too. When you do find the P wave, what you think is a P wave, try to match the P's and QRS's to understand the relationship or lack of relationship. Then you can pinpoint the diagnosis, confirm it, and go from there. So let's talk about a few things. So there are some rhythms that can be recognized at first glance, like some things in life, art, etc. You look at them once, you don't need to go through an elaborate algorithm to know what you're dealing with. Let's just do an example. This is a narrow complex tachycardia. The clinical context is shown below, a 19-year-old asthmatic woman with extreme dyspnea. So you already know what this clinical scenario looks like. Young person, probably very unlikely to have any sort of structural heart disease, who comes in with this ECG, and you can imagine what she looks like clinically before you even look at her. Probably somebody in extreme distress. Her adrenaline level is through the roof. The next thing you do is look for P waves. Can you see P waves? We all agree it's a narrow complex tachycardia. The rate's something like 160, 170 beats a minute. And there are actually P waves here if you look carefully. They're little deflections of the preceding T wave. So upright P waves in lead 2. What is this rhythm? This is classically sinus tachycardia. This is a very classic physiologic rhythm, the most common of all supraventricular tachycardia. This is the one that every single one of us experiences probably daily, if not daily, close to daily. And it's perfectly physiologic. If we get on a treadmill in the morning and exercise, we're going to have sinus tachycardia. If we're suddenly startled, we'll have sinus tachycardia, etc. The overall P wave axis and morphology are normal. The atrial rate's typically 100 to 200. There's a 1-to-1 P to QRS relationship. For every atrial impulse, there's a subsequent ventricular impulse. The PR interval is generally compressed because the AV node is revved up and conducting rapidly, because these are typically high catecholamine state physiology conditions. In this case, it's a pathologic condition, status asthmaticus, leading to a physiologic consequence, which is sinus tachycardia. This woman is in distress. Her adrenaline levels through the roof. She is gasping for air, fearing for her life, and her rhythm is what it is. And it's very important to remember this last point, which is that when you see sinus tachycardia, you have to understand the underlying reason. It's generally a responsive rhythm, not a primary arrhythmia. It's a physiologic condition that is reflecting some underlying, often pathology or condition, maybe even a physiologic condition like exercise. So you have to address the underlying condition. Sometimes, as you know, electrophysiology specialists will get called to a surgical floor for a sinus tachycardia case that's considered a tachycardia. Please help us with this. And it's somebody who's writhing in pain, or somebody with something else that's causing the problem. We have to treat the underlying source, like pain relief, etc., fever, not the rhythm itself. If you give beta blockers, for instance, if you just want to treat the rhythm because you don't like seeing a fast rhythm and you want to slow it down, and you treat this person with beta blockers, what will you do to somebody in status asthmaticus with metoprolol? You'll probably kill her because that last little bit of airway will close up. Point is straightforward. Next, let's now turn our attention to pathologic narrow complex tachycardias. This is another maybe Mona Lisa rhythm, something that you can look at right away and know. What are the P waves here? Well, there aren't really P waves, no nice upright humps. This is actually a T wave here. But what you see instead are these sawtooth downward going deflections, which are what the atrial activity are represented by in the CCG. And this is the classic presentation of atrial flutter. If you look at lead 2, the inferior leads, you really do have the resemblance of a sawtooth. It looks like a saw that you could use to cut wood. Number one. Number two, the ventricular rate is very regular. So the ventricular rate is very regular, and there's a sawtooth atrial rate going on. That's classically atrial flutter. The ventricular rate doesn't always have to be the same. It can be rapid or slow, but it's typically a factor of 300, because in atrial flutter, in general, the cycle that produces the rapid atrial rate travels at about 300 impulses per minute through the atrium, meaning through the atria, meaning that the AV node is hit or is stimulated 300 times a minute. But normal AV nodes generally cannot process impulses at 300 times a minute. So they block the impulses, either every other impulse, 2 out of 3 impulses, 3 out of 4 impulses, whatever it is, and they'll only let through a factor of 300 through. So if the atria are spinning around at 300 and the AV node only lets every other beat through, the ventricular rate will be 150. If every third beat is let through, the ventricular rate would be about 100. Every fourth beat, 75. Every fifth beat, 60. Every sixth beat, 50, etc. You get the point. But the atrial rate is generally much greater than the ventricular rate, and the level of AV block can vary. This is classic atrial flutter. If you look at it on a cartoon, typical atrial flutter is caused by this. There's a circuit of electricity that resembles a roller coaster spinning around and around in the atrium. The right atrium is the source of the pathology, and every time that impulse hits the AV node, that impulse will either conduct to the ventricles or block and not get conducted. And that's the reason for the ventricular rate and its atrial relationships. That's what atrial flutter actually looks like electrically. How do we deal with atrial flutter? Well, first and foremost, we have to think about stroke risk, because in atrial flutter, that rapid electricity traveling through the atria results in no organized contraction of the atria. And when there's no organized contraction, there's the possibility of blood pooling and settling in the nooks and crannies of the heart. And the nook and cranny that we're most concerned about is the left atrial appendage. And the left atrial appendage, blood clotting that can form because of lack of good movement of blood can lead to the potential of clot dislodgement to the brain and a stroke. So we think about anticoagulation in patients in whom atrial flutter is recognized, and we follow the same anticoagulation guidelines that we do for atrial fibrillation, which we're going to talk about in a second. But the core principle in atrial flutter management is that atrial flutter is actually a curable rhythm. Typical atrial flutter, which is that cartoon that I just showed you, can be cured, eliminated without recurrence about 98% of the time with a single procedure, catheter ablation. Let's talk about that. So in catheter ablation, many of you know this, and for those of you who want to see this, you're welcome to join us at Washington Hospital Center, where we do this all the time. Occasionally we'll take patients and do this at Georgetown. It's less common there. But they're brought into our electrophysiology suite, put into a fluoroscopic setup, and catheters are placed in the femoral vein. And often we'll put catheters in the right atrium near the bundle of His, and the coronary sinus, and the ventricle, or some combination, fewer catheters, or as many as these catheters, to look inside the heart. And when we put a catheter in the heart, what are we doing? We're making electrical measurements and learning about how electricity travels in the heart from within the heart. The ECG shows us electrical activity that gets projected to the body surface, but when we want higher resolution, when we want Google Earth Street View, so we're not just looking at your neighborhood from 5,000 feet up and can kind of recognize the cars and the houses. We want to look at each house and look in every window. Look what's going on in the living room and the family room of that particular house. Very, very high resolution, small field of vision understanding of what's going on. It's creepy for Google Earth, but not for the heart. Here, we're really trying to understand what's going on inside the heart, and catheters give us those eyes and ears inside the heart. So in atrial flutter, what's interesting is that we can see electrical movement, and if we reconstruct it, we often use these reconstruction tools that generate a color-coded appearance of the heart muscle tissue. So this is a magnified view of the right atrium in somebody who underwent intracardiac electrogram mapping and is in active atrial flutter. This is a representation of where the patient's face is. So you're looking at the heart with the face looking this way, and you're looking at the heart from this approach, sort of a left-sided approach looking at the right atrium. And what you're seeing here is this hole, this like blue area, is the tricuspid valve. And the color coding shows electrical activity from earliest, represented in red, to latest, represented in blue, with shades of red, then yellow, then green, then blue, demonstrating early, later, 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 latest. So what does this show? This shows electrical activity spinning around the tricuspid valve, much like a roller coaster spins around and around and around and around one of these loops. That's electrical activity. That's what atrial flutter is. It's electrical motion spinning around and around. That's what it looks like when you look at the electrograms inside the heart. So what if you wanted to stop a roller coaster that just is spinning without stopping around and around this track? What would you do? Would you throw beta blockers on it? Would you throw metoprolol roller coaster? Would you throw amiodarone at it? I'm not trying to be silly. I'm actually trying to highlight an important principle. Drugs don't work very well for atrial flutter. Once that circuit gets established and the electricity is traveling, metoprolol, beta blockers, calcium channel blockers, antirhythmic drugs generally don't do a lot of good. They can slow down the AV nodes so that the number of beats that get transmitted to the ventricles are reduced. So maybe an atrial flutter ventricular rate of 150 goes to 100 or something like that. But that doesn't stop the atrial misbehavior. The way to stop a roller coaster, how about if we put a concrete brick right here, change the tracks and put concrete on the tracks so the roller coaster couldn't travel anymore. That is what we do. And what's the concrete in the heart that we use? It's scar tissue. By delivering a catheter to the right atrium and heating the tissue between the tricuspid valve and the inferior vena cava, that little strip of tissue, dragging a catheter along this area. This is a pathology specimen. This is the tricuspid valve. This is the inferior vena cava. This is our catheter peeking up through the inferior vena cava, having been delivered there through a puncture in the right groin, the right femoral vein. We can drag a catheter across with heat energy and create scar tissue here. Scar tissue doesn't conduct electricity. So the next circuit, once that scar tissue is completely formed, that hits this scar, can't cross it anymore. So the flutter extinguishes, and the sinus node gets to breathe again and says, thanks so much. I've been punched in the face by this flutter 300 times a minute. And now the flutter is gone, so I can work again. So sinus rhythm is restored. That's how we cure atrial flutter. And it's not immodest to say cure. We want to use the word cure very judiciously, but this actually works. It stops atrial flutter and prevents it from happening. If the scar is complete and doesn't have breaks in it and is full, it'll work 100% of the time. There won't be any more typical atrial flutter again. When you do this procedure and you put catheters inside the heart, this is to show you what we can see. These sharp spikes represent electrograms, and where these electrograms are actually generated from are within the right atrium. So this, what you're seeing on the screen, is actually a catheter that was placed in the right atrium that looks like a halo. It's a circle, and it has poles spanning the tissue all the way around the atrium. So wherever that circuit travels will be captured as a spike on each of these poles, one after another. Boom, 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 boom. In this case, the poles are numbered, and this is at what we call a counterclockwise from pole number 19 and 20 down to pole 3 and 4. 19 and 20 is here, 3 and 4 is here. So 19, 20, 17, 18, 16, 15, whatever, all the way down, spinning, 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 and we see these rapid deflections. This does not look like a typical ECG. The typical 12-lead ECG is shown up here. It's this crude, fat, low-resolution image of what's going on in the heart. The high-resolution misbehavior is being captured here by intracardiac electrograms. That's to show you how powerful these intracardiac electrograms are in letting us understand what's going on inside the heart. When we actually treat the flutter and do the ablation and that circuit can no longer travel, boom, it stops. The flutter breaks and normal sinus rhythm is represented by this nice P wave on the surface ECG resumes. And this is what a normal P wave looks like intracardiac. It's a single spike happening at whatever, 60 times a minute, not 300 times a minute. Okay, next, that's enough about atrial flutter, but it was worth a discussion so you get to see all of the field of electrophysiology encapsulated in how we recognize, diagnose, and treat one arrhythmia, atrial flutter. Let's move on to atrial arrhythmias that are not flutter. This is another one. You can recognize it at first glance. It has some features that kind of resemble atrial flutter. You might be misled to thinking so because of this coarseness in V1, but if you look at the rest of the rhythm, it's not quite adding up. The ventricular rate is irregularly irregular. There's nothing that looks like a normal P wave here. There's just kind of electrical chaos going on. And what's this rhythm? This is, of course, atrial fibrillation, the irregularly irregular ventricular rhythm with no organized atrial activity at all. Multiple reentrant atrial wavelets. There's nothing that looks like a nice, clear, upright hump, solitary hump in the inferior leads that would be a P wave. The atrial rate's faster than the atrial rate in atrial flutter. In atrial flutter, there's an oscillation of the atria at 300 times a minute. In atrial fibrillation, there's just electrical chaos up there, 3, 4, 5, 6, 7, 800 time a minute electrical chaos in the atria. And of course, that's far faster than anything the AV node can handle. Thank God for that. The AV node protects our ventricles. Imagine if we were able to conduct every atrial impulse one-to-one to the ventricles. What would happen? Atrial flutter would become ventricular flutter, a ventricular rate of 300. Atrial fibrillation would become ventricular fibrillation, a ventricular rate of 700 or 800. And that's, of course, incompatible with life. So the ability of our AV nodes to block, to filter rapid atrial rates from invading the ventricles keeps us alive. That's what protects us from atrial arrhythmias. That's why atrial arrhythmias aren't deadly, whereas ventricular arrhythmias can be. This is what atrial fibrillation looks like in cartoon format. The atria are quivering like a bag of worms, no organized activity at all. The sinus node is completely suppressed. It's getting punched in the face at 700, 800 times a minute. It can't work. It can't get in a word in edgewise because it's suppressed by this atrial chaos. The AV node is similarly being bombarded by all this, and it will conduct as best as it can, as rapidly as it can, based on its normal intrinsic physiology. In an elderly patient with AV node conduction disease, when there's a lot of fibrous tissue in that AV node, it might conduct slow. So atrial fibrillation may be conducted in the ventricles with a slow response, a bradycardic response. A young person who has atrial fibrillation in a really robust AV node may conduct atrial fibrillation to the ventricles with a rapid response, 200 beats a minute, 180 beats a minute. If there are drugs on board that slow the AV node, those rates can change. But the bottom line is the atrial rates are chaotically fast and no organized contraction at all. It's just quivering, and the ventricular rates are irregularly irregular. So it's important to know a few physiologic and epidemiologic elements of atrial fibrillation because it is the most common pathologic heart rhythm disorder that we see in human adults. It's a global epidemic, 30, 40, 50 million cases are being treated right now with more new ones happening year after year. Prevalence and incidence numbers continue to rise. Men experience it more than women. It's very age-related. So atrial fibrillation is very rare in young adults, but very common in the elderly, and it becomes a little more prevalent as time goes on. I just came out of a patient room who was newly diagnosed with atrial fibrillation, and he asked me, well, why did I get atrial fibrillation? And I said, our best understanding is the reason that we get atrial fibrillation is very similar to the reason that we get gray hair. It's the aging process acting on the heart. Not everybody gets it, but about 20% of all people over the age of 80, 85 get atrial fibrillation. The highest prevalence in the world actually happens to be in North America. Other parts of the world have lower prevalence, but it does affect people worldwide. And there are other factors beyond aging that can accelerate or decelerate the age at which atrial fibrillation develops. So Genetics is very important. Other conditions are important as well. We all have some degree of predisposition to atrial fibrillation as we get older, but perhaps by staying in good shape and not being obese, not having sleep apnea, not having hypertension, we might delay our genetic programmed AFib start date from maybe the 80 that it was programmed to be to 100 or 120, 130, so we never experience it. Other people who may not take care of themselves as well may develop AFib earlier. So you get the point that it's a multifactorial condition that has as its core reasons or etiologies the aging process and intrinsic genetics. There's a form of atrial fibrillation that we call acute atrial fibrillation that everyone who's listening to this, every one of us might experience if we provoke the heart enough. If you stimulate your heart or toxify your heart with alcohol, binge drinking, for instance, holiday heart syndrome, you can toxify the atria and make them fibrillate. If you overdose on caffeine, we've seen house staff who were up all night, busy, stressed out, drinking Red Bull and espresso to stay up, who showed up in the morning with AFib. They're completely normal. They've never had it before, but they just so provoked their heart, so stimulated the heart. And we can replicate this in the EP lab. If we pace the atria very, 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 very fast, we can throw it into AFib, generally just transiently. A lot of other things too, like acute stress, high fever drugs, any sort of cardiac insult like surgery, myocarditis, trauma, hyperthyroidism, etc. All of these things can cause atrial fibrillation acutely. They cause AFib. And the way to treat that AFib is to treat the underlying insult. So somebody who has high stress up all night on caffeine, let them rest, get them over the hump, and then the AFib goes away. Hopefully it won't come back if they don't keep doing those behaviors. So that's acute AFib. It's one type of AFib. Successful treatment of the underlying insult will eliminate the AFib. That's not the AFib that we see typically in clinical practice. The AFib we see in clinical practice is the AFib associated with aging and genetics and other heart conditions. We call that non-acute AFib. It's AFib that doesn't happen because of a particular provocation. It looks like it happened out of the blue. Yeah, maybe there was some spark that triggered that particular event, like high heart rate, or drinking something cold, or no obvious provocation at all. The AFib just happened. That's typically what it looks like when somebody with non-acute AFib develops their first episode. And it often starts off as being paroxysmal, meaning an episode of AFib that happens, then stops within a week on its own, and then comes back, stops within a week, and it's on its own. Typically, these episodes start off as being minutes long apiece, then hours. Then as time goes on and nothing is done, paroxysmal atrial fibrillation gives way to persistent atrial fibrillation, in which the AFib is present and is in place for a week or more, and something needs to be done to get the patient out of atrial fibrillation, like an electrical cardioversion to correct the rhythm, or a drug to stop the AFib. If that's left alone and nothing is done, persistent atrial fibrillation can give rise to what we call long-standing persistent AFib. That's AFib that's present constantly without interruption for at least a year. And that's what happens next. And if we decide, as we do in some people, elderly people who aren't symptomatic, for instance, or somebody who just cannot be kept out of AFib, if we decide to just abandon efforts to suppress the arrhythmia, abandon efforts to restore sinus rhythm, we call that rhythm permanent AFib, meaning the AFib is there all the time. We're just letting the AFib win. The atria have been taken over by the AFib, and we just want to control what's going on in the ventricles because that's the best that we can do. So those are the different categories. And again, not to be silly, but to give an example, when I talk to patients, I sometimes liken this to dandelions or weeds in your garden. They start off as being here and there, occasional, widely separated, that's paroxysmal, or lots of them, persistent, or when the whole garden is taken over, long-standing persistent. And if you're not going to do anything about it, but let the weeds take over your garden, we call that permanent. Okay, why do we care about AFib? Well, from a health perspective, the number one reason is stroke risk. You all know this. Somebody with AFib is 5 times more likely to have a stroke than somebody without AFib if you match every other health parameter. So we've got to think about stroke. 15% of all strokes occur in patients with AFib. Stroke risk is a problem because having a stroke can be deadly, and stroke risk doubles the total mortality of atrial fibrillation versus normal and condition-matched age and condition-matched normal sinus rhythm. So it's a serious problem. Strokes in AFib are also particularly severe, not just because they make the likelihood of death higher, but if you look at AFib strokes, they're more deadly than non-AFib strokes. Strokes that occur because of cerebral vascular disease, etc., are apparently less deadly. AFib-related strokes are more likely to kill and more likely to debilitate, meaning render somebody with such impairment neurologically that they are bedridden. It's really not pleasant. A stroke, in many people's opinion, in some respects, can be worse than death, arguably, if the paralysis or the impediment to normal life is so severe, the pain on the patient and trauma on the family, etc. So it's something to be taken very seriously. So anything we can do to minimize risk is our prime directive in AFib. And what's very interesting is that the likelihood of stroke in atrial fibrillation that's non-acute, so the AFib that keeps coming back, whether it's paroxysmal or persistent, long-standing, or permanent, the risk of stroke in any of these categories of AFib is actually the same in a given individual, meaning that the absolute burden of AFib doesn't increase or decrease the rate of stroke. So you could have AFib episodes occurring several hours a day, all the time, once every few days, etc. So wherever the burden of AFib is, the stroke risk stays constant as this changes. It's an important principle to recognize because the risk of stroke in a given individual with atrial fibrillation is actually determined by non-AFib risk factors. What are they? Well, they're kind of all summarized here in an exhaustive way. The ones that we're most interested in is hypertension. Or hypertension is one. Somebody with hypertension has an increased risk of stroke. In this case, it's about a 6% annual rate of stroke in AFib as an isolated risk factor. Peripheral vascular disease or cardiac disease of any type increases the risk of stroke, including a prior MI and heart failure. Diabetes increases the risk. Having had a prior stroke, so if you only have time for one question to somebody who has atrial fibrillation that keeps recurring, your question could be, sir, ma'am, have you ever had a prior stroke? And if the answer is, oh yes, as a matter of fact, I had a stroke 2 years ago, that instantly puts that patient at a 12% yearly risk of stroke without looking at anything else. It's the single most potent risk factor for stroke. That's a common phenomenon in medicine, right? A common principle of medicine is that things that happened before are more likely to happen again. So always ask about things that may have happened before, in this case, stroke. Other factors are age, which is important, over 65 or over 75. So what are our guidelines? How do we manage atrial fibrillation? Or our goals therapeutically are top of all, first of all, thrombosis control, address the risk of stroke. Then when the risk of death and debilitation is addressed appropriately to the best that we can, we think about comfort, like rates, so that heart rates aren't too accelerated, and the heart rhythm is normalized, so the patient is in normal sinus rhythm. And the reason that we care about comfort is because we're here not just to save life as doctors, as physicians, as caregivers, but to improve life. And atrial fibrillation can cause symptoms. It can cause people to feel palpitations, fatigue, dyspnea, misery. They're just not happy. They can't do what they like to do. Not surprising. When people are in AFib, it's like their car engines are knocking. The horsepower that propels their life force is diminished in many cases, and that can cause symptoms. What's interesting is that this is just some questionnaire data showing that this really does have an impact on symptoms, but in a more global sense, symptoms of AFib are not one size fits all. They're not stereotypical for everybody with AFib. They can be very variable. There's some people who are debilitated with their episodes of AFib. When they have paroxysms of AFib, I had a patient tell me that his paroxysms were so bad that even though they didn't occur frequently, but when they did occur, he couldn't get out of bed. He couldn't walk across the room, and he was so miserable and so fearful of these things happening that he was looking on the internet for ways of killing himself because he couldn't deal with this anymore. Can you imagine that? That's debilitation with a capital D. And then there are other people on the other extreme who are totally unaware of their AFib, whether it comes and goes, is there all the time. I had a patient who showed up to my clinic for the first time. I met him when he was referred by a doctor who newly recognized him to have AFib. When we dug in deeper, we saw that he had had long-standing AFib for the previous 20 years. He had been in AFib for 20 years, totally unaware that anything was wrong. Not only that, he was 74 and every year in the summer was swimming across the Chesapeake Bay doing that 4-mile Chesapeake Bay swim. So not only was he not debilitated, he was in better physical shape than most 20-year-olds. I don't know how many people listening to this, maybe all of you can, but I know I couldn't swim across the Chesapeake Bay, and he did so in full-blown AFib. How do you reconcile debilitation with almost super quality performance, and then of course things in between? It's not quite clear, but it really highlights the fact that every individual is an individual, and all of us in medicine, as we go through our lives, our professional lives, our caregiving experience, have to recognize that we don't use a one-size-fits-all phone app way of dealing with medical problems. We have to address every individual as an individual and treat that person appropriately. So what's one of the ways that we can suppress the AFib arrhythmia and restore sinus rhythm? Well, we can use antiarrhythmic drugs. This is an exhaustive summary of basically every antiarrhythmic drug that we have available to us. The simple answer to antiarrhythmic drugs in AFib, or the simple summary, is that they don't work very well. You would give them a C- or a D if you were grading their papers in grade school. This is just a simple study showing that over a meta-analysis work on patients treated with antiarrhythmic drugs, AFib was suppressed effectively and sinus rhythm was restored about half the time, a little over half the time. And placebo was associated with some degree of sinus rhythm maintenance because, of course, AFib comes and goes. This just goes to show you that drugs aren't so hot. Not only that, but drugs can actually cause problems in some clinical conditions. There are categories of AFib suppressing drugs like the class 1C antiarrhythmics, flecainide, enconide, propafenone, that actually can increase mortality. And there are reasons for that. We can talk about that later. Amiodarone is a drug that you've heard of, that you use. You've seen it on the wards. It's the most potent heart rhythm drug that we have available to us. It's been FDA approved, but it actually can be very toxic. It has iodine in it that deposits in the body, and long-term use can be associated with organ toxicity. Also, what's interesting, not everybody knows this, is that amiodarone was never labeled for treating atrial fibrillation. It got an original FDA label to treat ventricular fibrillation, and people assume that all fibrillation was alike, and so they've used it for AFib as well, but it's not technically labeled for AFib, still isn't. So you have to be very careful when using it and tell patients about potential risks of using amiodarone. We use it like water, but we really, to be good doctors, have to tell patients about the risks. When drugs don't work, what do we do next? Well, ablation is the next level of invasiveness. And what is catheter ablation based on? This is an image of the left atrium. It's a schematic. This is the heart. If I turn it to the back, the left atrium is the left upper chamber of the heart. These are the pulmonary veins that plug into the heart. What's very interesting is the pulmonary veins are enveloped in left atrial heart muscle. Fascinating. This has been recognized for about 150 years. Why that is not completely understood. But what it sets people up for is that if there's abnormal electrical activity, as is commonly the case in the origination of AFib in the vast majority of cases, from the muscle tissue that envelops the pulmonary veins, that abnormal activity can conduct along the muscle, enter the left atrial muscle tissue itself, and lead to atrial fibrillation. It's almost like I think of a heart that's beating normally as a left atrium that looks like a calm pond on a summer day. So the water is perfectly still and happy. That's sinus rhythm. And think of the pulmonary veins as dirt roads leading up to the pond. And out of the blue, these kids come running down the dirt roads and start throwing pebbles into the pond. And those pebbles ripple and interact with other ripples, and pretty soon the whole pond is rippling. That's kind of a metaphor for atrial fibrillation. And to treat it, what has been developed is this technique of catheter ablation. By delivering a catheter to the left atrium via the right femoral vein, we can actually heat or cauterize tissue that surrounds the pulmonary veins and create a ring of scar tissue. And as you saw from that atrial flutter example, when you create scar tissue in the heart, you create an electrical barrier to electrical movement. So those rocks, that electrical conduction that tries to get into the heart from the pulmonary veins, can't, because it hits the scar tissue and gets extinguished. So it's kind of like putting a fence around the pond. So you can throw all the rocks you want, they'll just hit the fence and bounce right back. So this is a schematic of 3D mapping and ablation using point burning, where each of the red dots represents a burn, creating scar tissue. We also do this with freezing, and that's been shown to be a very effective strategy. And we're about to launch a clinical trial right now in MedStar of two competing technologies that are brand new, that hold enormous promise for being able to generate these lesions very effectively and very quickly. That's called pulsed field ablation. Stay tuned for more data on that. Okay, let's wrap up the last few minutes of this. We've talked enough about AFib, but we gave it the most attention because it's the most common pathologic narrow complex tachycardia in adults. Let's wrap up by talking about the non-AFib, non-A-flutter pathologic supraventricular tachycardias. And what are they? There are basically three that we want to talk about, and these represent the vast majority of these tachycardias that are not atrial fibrillation or atrial flutter. And they are AV nodal reentrant tachycardia, AV reciprocating tachycardia, and atrial tachycardia. These three entities. And if you look at them in terms of prevalence, so if somebody has a narrow complex tachycardia that's not sinus tachycardia, not AFib, not flutter, it's most likely to be AVNRT if it's an adult. Second most likely to be AV reciprocating tachycardia, and less likely to be an atrial tachycardia. And these are rough prevalence numbers. We'll go through each of these in just a second so you understand better. In children, these two are flipped. Kids are more likely to have AV reciprocating tachycardia if they experience a narrow complex SVT, and second, would most likely to experience AV node reentry. So let's just start by talking about this. What is AV node reentry? AV node reentry, AV nodal reentrant tachycardia, is a pathologic narrow complex tachycardia that occurs because of paroxysmal spinning around arrhythmia or a short circuit that hijacks the heart that's occurring within the AV nodal tissue itself, the region of the AV node. What does that look like? It looks like this. This is in slow motion, where that red burst in the middle represents a sudden short circuit that develops within the AV nodal tissue. And with each spin around, it will conduct down into the ventricular conduction apparatus, generating the ventricular depolarization and ventricular contraction, and also conduct backwards up to the atria and generate an atrial impulse and subsequent contraction. That's not physiologic, but it's very interesting because it highlights an important principle, which is that conduction in the heart is direction agnostic. Depending on where the impulse originates, the conduction can travel in the appropriate direction from the origination point. Heart conduction is kind of like Route 95. You can travel northward or southward on Route 95. Heart muscle is just muscle. Electrical conduction can travel in whatever direction it's driven. If you put a pacing catheter here in the apex of the heart and pace the heart rapidly, you'll drive an impulse from the apex of the heart backward up through the AV node into the atria. Normally, electrical conduction starts up here in New York City at the top of 95 and travels down toward DC, then down toward Miami. New York, DC, Miami. That's the metaphor for Route 95. In AVNRT, it's as if you have a short circuit going on right in Washington, D.C., sending a backward signal northward toward New York and a southerly directed signal down toward Miami. Think about what this does to the heart. Somebody with AVNRT in whom the atria and ventricles are squeezing rapidly by this impulse generated in the middle of the heart are squeezing atria and ventricles simultaneously. And that's not physiologic, right? Because when the ventricles squeeze, what happens to the tricuspids and mitral valves? They're closed. So that means that when the atria are trying to squeeze against them at exactly the same time, there's a backward wave of blood going up to the neck. So people with AVNRT tend to feel palpitations, rapid heartbeats, a pounding in their neck because of that backward wave that's going on. And their ECGs typically look like this. What's interesting in them is that if you look at V1, which is a good place to look, they don't have an obvious P wave at all that precedes the QRS complex. What they have is atrial activity that often follows the QRS right afterward. We call this a pseudo R prime or a retrograde P wave. And the way that we manage the measurements of these arrhythmias is by checking the distance between the QRS complex to the subsequent P wave. And if it's a short distance, we call that a short RP tachycardia. That's a short distance from the QRS complex to the subsequent P wave, and it reflects what's going on here, because in this arrhythmia, the impulse is generated from the center of the heart and traveling to the atria and ventricles. If the atria and ventricular depolarization happen perfectly simultaneously, the P wave won't be seen at all. It'll be buried within the QRS because the ventricular muscle generates so much more electrical amplitude, and you see no P waves at all. So if you see a narrow complex tachycardia with no P waves at all, that's a classic hallmark for AVNRT. That's why looking for the P wave is so important. And when you can't find it, chances are it's AVNRT. But often there's a little bit of a delay because the ventricular apparatus, the ventricular conduction highway, is faster than the atrial one is. So the impulse gets backward to the atria a little slower than it does to the ventricles. So you see this little delay and a pseudo R prime just after the QRS. This is what typical AVNRT looks like. We have this little blip. We call this the pseudo R prime right after the QRS complex. And the intracardiac electrograms, I won't go into too much detail here, but the simple thing is that this is the arrhythmia that we say you can diagnose from the other side of the room, because the intracardiac electrograms, this is showing you what it looks like in the coronary sinus and in the atria and in the bundle of His and the ventricular surface leads. All of the electrical activity is happening roughly simultaneously. That's why you can almost draw a line from top to bottom here. That's classic for AVNRT. And why it happens is that these people develop slow conduction as well as normal conduction in the area of the AV node, and that can lead to a short circuit, fast, slow spinning around that occurs. I won't go into too much detail here other than to say that the way to fix this, to treat it, like other arrhythmias, is to burn the abnormal tissue. So the tissue that's developed that abnormally slow conduction, slightly slower than its neighboring tissue, we just simply burn. So we drive electricity down the normal pathway. One way of thinking about it is if you have Route 95 and all the traffic is traveling at 60, 70 miles an hour, there are no accidents because everybody's traveling fine. But imagine if there's an area of road right in the middle where there are a bunch of potholes in one of the lanes and people have to get out of the pothole. They have to drive slowly to get out. Well, they have to change lanes or whatever to spin around. That could cause accidents. That's the source of problem in AVNRT. So if you just block traffic from traveling down the slow lane, you'll have restored the homogeneity of speed, no more accidents, no more AVNRT. We do that with catheter ablation. And the area that we ablate is shown here. This is the slow pathway of the AV node. It's south, that is inferior to the normal AV node and a little bit posterior to it near the os of the coronary sinus. Okay, I'm going to rapidly go through these other two tachycardias in the last couple of minutes. AVRT is AV reciprocating tachycardia, the next most common. SVT, that's not fib, flutter, or sinus attack. And this is caused by the presence that has persisted after birth of an accessory pathway. So when an accessory pathway is present connecting atria and ventricles, accessory meaning in addition to the AV node, you have the setup potentially for a short circuit. Why does this happen? Well, in our mother's wombs, when our hearts were developing, the heart started off as a blob of tissue, then separated into atrial tissue and ventricular tissue, separated by endocardial cushions that don't conduct electricity, with the only electrical connection being the AV node, the muscle connecting atria and ventricles. That's normal. We want to have one gatekeeper, one pathway for electricity to travel to the atria into the ventricles. But if that separation process was incomplete, and there's a little bit of muscle tissue that gets left behind connecting atria and ventricles, you could potentially have a secondary circuit. So in addition to the Route 95 pathway, you could have a Route 1 here. That's another bypass tract between atria and ventricles. And if you have conduction that travels down the AV node, retrograde up the accessory pathway, then back down the AV node, you could have a setup for an arrhythmia that spins around there. And those types of arrhythmias that are spinning around can go down the AV node, then back up the accessory pathway. That direction we call orthodromic reentrant tachycardia. If it's backward, the arrhythmia traveling down the accessory pathway, then retrograde up the AV node, then down the accessory pathway, we call that antidromic reentrant tachycardia. This is less common, but both of these are considered AV reciprocating tachycardia. The atria sends a signal to the ventricle, which reciprocates and sends it to the atria, which reciprocates and sends it to the ventricle. The gift that keeps on giving. That's the AV reciprocating tachycardia. In these patients, if they have atrial fibrillation, that could potentially be a dangerous situation because the normal rate governance property of the AV node might not be present in the accessory pathway. So can you imagine if you have an accessory pathway that's able to conduct 500 impulses a minute? What happens in atrial fibrillation with an accessory pathway? That could potentially turn into ventricular fibrillation. So these can be deadly. That's why they need to be recognized and treated and potentially ablated when necessary. And catheter ablation is first-line therapy. We deliver a catheter to the tissue, find where the accessory pathway is, and burn it and get rid of it. Now we've taken away Route 1, we've restored the heart to normal. Only Route 95 through the AV node can conduct electricity, and the patient's back to normal again. Catheter ablation for AV reciprocating tachycardia is most commonly done in the left lateral territory because about 60% of all of these accessory pathways, for reasons that aren't fully understood, physiologically end up being in this area. And that's kind of nice too, because that area of the heart is easy to get to, this left lateral territory near where the mitral valve sits all the way out here. We can get there pretty easily with a catheter and burn those locations. These tend to be very successful procedures, and they're very satisfying because you take patients that have symptoms or potentially dangerous phenomenon and restore them to normal. Okay, last entity is atrial tachycardia. It's less common, but we'll quickly go through it. This is a situation in which you have electrical activity. This is showing you an atrial tachycardia that's got adenosine, and then the patient has no AV node conduction, but the atria just keep on ticking, A. And then in this case, there's rapid degeneration into atrial fibrillation. But this is an example of atrial tachycardia in which there is a rapid atrial rate that originates from atrial tissue that's not sinus tissue, not exactly the sinus tissue. This is showing you an atrial tachycardia originating from a common hotspot, which is the mitral annulus, the mitral valve apparatus, just cells that are abnormally out of the blue starting to conduct rapidly. We can talk later after hours or another time about why this happens, but suffice it to say that it's an alternative sinus node. There's tissue that's taken over the pacing of the heart, saying, I'm going to be the sinus node. Sinus node, move over. I'm going to pace this heart. Rapid pacing originating from an ectopic site is what we call an atrial tachycardia. How do we get rid of these? You got ablation. We find that tissue, we find those cells, and simply apply point heat energy to them and silence them, and the sinus node gets restored. This is showing you a 3D map of a patient who's referred to us, quote unquote, with atrial flutter for ablation. Somebody at another facility had tried atrial flutter ablation on, but the arrhythmia kept recurring. The reason the arrhythmia kept recurring was that it wasn't atrial flutter at all. It was an atrial tachycardia. This is a 3D rendition of the right atrium, 3D rendition of the left atrium generated by intracardiac electrograms when we mapped inside the heart. And what does it show you? Remember, the color scheme shows earliest activation with red, latest activation with purple. In sinus rhythm, where should we see earliest activation? Right up here, red in the sinus node, and then maybe a little bit of yellow, then green, then blue, then purple later and later and later. In this case, the red is showing up here in the mitral valve, which is a common hotspot for atrial tachycardia. So the pacing of the heart is originating from this tissue. Red is here, then yellow, then green, then blue, then purple, as far away as possible in the right atrium. So backwards. So the impulse is arising from the left atrium, then traveling toward the right atrium, abnormal, rapid, by applying heat energy here with a catheter. This was fixed, solved, sinus node restored, didn't come back, the patient was happy. This is just showing you some common hot spots where these things occur. Mitral annulus being one, the crista terminalis commonly seen where we find these. There's some physiologic reasons why this happens, but they're pretty straightforward to find and ablate. It's just that atrial tachycardia is not enormously common. Again, all non-selected SVTs that aren't flutter or fib taken together, only about 10% of them are atrial tachycardia. So we can use drugs for any of these supraventricular arrhythmias, but as we've seen before, some drugs aren't so helpful and they can be toxic. But in general, for SVTs, drugs don't work very well. So they're not first-line therapy for flutter, and they're not first-line therapy for other SVTs that are not fib or flutter, like AVRT, or atrial tachycardia. But we still sometimes use them in people who really don't want to have a procedure, or in addition to a procedure, if we have some residual, for instance, AFib after AFib ablation, etc. So let's just summarize a few words here on atrial fibrillation, which we started talking about. It's the most prevalent pathologic supraventricular arrhythmia. It increases the risk of stroke by 5-fold, causes 15% of all strokes, and our therapeutic goals are first and foremost thrombosis control to eliminate the risk of stroke, rate control followed by rhythm control. Catheter ablation for AFib is more efficacious, but it is a little more invasive than drug therapy to restore sinus rhythm. And ablation is first-line therapy for atrial flutter. Atrial flutter we speak of also in conjunction with AFib because it's kind of like a cousin of AFib. It's an organized single-circuit cousin to the chaotic multi-circuit atrial fibrillation. SVTs that are not fib or flutter, sinus tach is the most common. It's a physiologic rhythm, AVRT, and atrial tachycardia, the principal. 3 non-AFib, non-flutter SVTs in adults. SVTs, like all arrhythmias, depend on an anatomic substrate, and catheter ablation, when applied to that substrate, can cure pathologic SVT. And I'm going to close with a very important reminder to think about humans as being very diverse, not just in physical appearance, but in physiology and in structure on the inside, and genetics, and constellation of other conditions. We have to treat every individual as an individual. That's our mission.